Good afternoon. I'm Serena Collado, Director of Community Health for Robert Wood Johnson University Hospital, Somerset. Welcome to our webinar, The Prostate Paradigm, presented in collaboration with Friends Health Connection. During today's webinar, we will provide an overview of common urological conditions such as incontinence, benign prostatic hyperplasia, and prostate cancer. We'll discuss risk factors, signs, causes, diagnostic testing, and surgical options, including the Da Vinci robotic surgical system. We are joined today by Dr. Dhiren Dave, a urologist and robotic surgeon with Robert Wood Johnson Barnabas Health's medical group and Robert Wood Johnson University Hospital, Somerset. So thank you for joining us. We will begin our webinar with about 20 minutes of moderated discussion, and then we'll open it up to questions from our audience. So again, Dr. Dave, thank you for joining us. Let's first start, if you could, by having you tell our audience a little bit about yourself, giving your background and what types of conditions you commonly care for as a urologist.
Sure. Thanks for the introduction, Serena. This is definitely unusual circumstances. This is my first time doing a webinar. So it's a little bit strange for us. As you know, every year we host this program since September is Prostate Cancer Awareness Month. And so a little bit about myself. I'm a urologist. I specialize in urologic oncology. I treat all types of cancers of the urinary tract, and prostate cancer tends to be the most common of all the cancers that I treat. My background is urologic oncology. I trained at UCLA. I've done an advanced robotic surgery fellowship, which I did in Seattle prior to coming to RWJ Somerset and starting the robotics program there in 2010. Prior to that, I'm a native of Salt Lake City. I grew up in Salt Lake City. I went away to college to Baltimore, where I went to Johns Hopkins. I went to medical school in Nashville, Tennessee at Vanderbilt. So I've been all over the country, but now my family lives here. I've been here for the last 10 years. I have two little daughters who we're raising here. So I now call New Jersey my home. So that's my background, but I really enjoy taking care of cancer patients. And today I think we're going to have a little bit of a focus on prostate cancer.
Yes, definitely. So thank you for that brief overview. So now, again, let's give our audience a quick overview of the urinary tract, like how it works and what organs are involved, if you may.
Sure. So normally I have PowerPoint presentation. I have one for you guys today. Unfortunately, I can't show it. We had some technical issues, but so we're going to do basically like a question and answer format. So the urinary tract comprises everything from the kidneys down to the urethra, and basically everything associated with production of urine, storage of urine, and release of urine. In men, that includes the kidneys, the tubes that lead down to the bladder from the kidneys called the ureters, the bladder, the prostate gland, the urethra, the penile organ. In women, it's essentially the same, except females do not have a prostate. But everything from the kidneys down all the way to the urethra comprises the urinary tract.
Okay, so thank you so much.
Mm-hmm.
Well, September marks National Prostate Cancer Awareness Month, and so since it's Prostate Cancer Awareness Month, let's start to maybe talk or have a discussion about the prostate. What is the prostate and what is its function?
Is a gland, an organ that produces typically some sort of a product or fluid, but the prostate's a walnut-shaped gland. It's located kind of at the base of the bladder. It surrounds the urethra, which is the channel that urine goes through when you urinate. And it's an organ for sexual function. It produces fluid that is part of the ejaculate or the semen, and it basically directly deposits the fluid into the urethra during sexual activity for the purpose of reproduction. So it's a reproductive gland. It sits at the base of the bladder, and it surrounds the urethra. And once you're done having kids, technically you don't need it, but the problem is it stays with you your whole life. And as you get older, it does tend to enlarge and get bigger. And sometimes that can cause issues because it basically compresses the urinary channel and can cause difficulty with urination. And the other problems we see, people can get cancer within the prostate gland. So.
Okay, thank you. That was very comprehensive explanation. So, one of the things I know people are always concerned about is prostate cancer. So maybe let's start with who is at risk for prostate cancer?
So prostate cancer is the most common cancer in men, second to skin cancer. So we call it the second most common non-skin cancer in men. It's the second leading cause of cancer death in men and accounts for approximately almost a third of all newly diagnosed cancers for men. Approximately 200, just over 200,000 new cases diagnosed every year. And every year we see roughly 29,000 deaths from prostate cancer. So a man's overall risk of developing prostate cancer is about 1 in 6 or 17%. And your overall risk of dying of prostate cancer is about 1 in 30, almost 3%, which is fairly substantial. In terms of risk factors, we know age is a risk factor. We know that as you get older, the chances of you developing cancer increase. Race is also important. People who are African American have an increased risk of not only developing prostate cancer, but developing a more aggressive form of the disease. So they are more likely to be at risk of dying of prostate cancer compared to non-African American men. And then also we know family history plays a role. So if you have a first degree relative, your risk is going to be significantly increased. So for example, if you have a father or brother with prostate cancer, the risk goes to approximately 1 in 4 or 25% from an overall risk of 1 in 6 in the general population. So there are some also other things that have been researched, dietary things. So a high fat diet, obesity have also been linked to increased risk of developing prostate cancer. If the cancer is significantly advanced, in those cases, because of the cancer within the prostate, it can cause obstruction to the urinary tract. It can cause there to be blood within the urine. As it grows, it can also obstruct urine flow from the kidneys and lead to kidney damage or kidney failure. Also, in patients who have metastatic prostate cancer, metastatic means when the cancer is spread outside the prostate. The two most common places for it to go are the lymph nodes and the bones. So when patients have cancer in the bones, it can cause pain. So, and most of the symptoms for prostate cancer occur in patients with advanced disease, but our goal is to identify men before they develop advanced disease. And so in most of those cases, we are not going to see specific symptoms related to the cancer itself. So therefore, we do recommend and advise that patients discuss screening for prostate cancer with their primary care physician to pick up the cancer.
What actually causes prostate cancer?
So similar to many other cancers, the causes are probably multifactorial and not just necessarily one thing. We know that genetics and family history do play a role. There have been many genes that have been identified that are associated with development of cancer, what we call oncogenes, and certain mutations can lead to that. And so some of those will be passed on from between family members. That's why family history is a known risk factor. Outside of that, many cancers develop due to in situations where there's no family history. And when that occurs, it's because something happened within the organ. So in the prostate, there were mutations that occurred that led to abnormal growth of cancer cells. Now, this happens, we have damage that occurs to our cells all the time, from ultraviolet radiation, from just walking around, even the sun. So there's damage that occurs to your cellular DNA at all times, and your body has mechanisms to repair that. And in certain cases, when you have mutations in certain genes, you have certain abnormal pathways, your body's not able to repair, and it leads to abnormal cell growth, which eventually then leads, but there's some connection. So it probably has to do with things like free radicals, things that damage your DNA and lead to abnormal cell growth. So we're all at risk of cancer development as we get older, just because that's the way our body functions, or in some cases fails to function over time as part of the aging process.
What is a PSA test and who should get it? And what causes PSA levels to rise?
So PSA is a blood test. It's been around since about the 1990s when we first started using the test to screen for prostate cancer. It's a protein that's produced by the prostate gland, and actually it's used to, it's an enzyme that functions to liquefy the seminal fluid. And it was discovered that when PSA is elevated, there is an increased occurrence of prostate cancer, but it is it's not diagnostic, meaning if a PSA is elevated, it does not mean you have prostate cancer, because other things can cause it to be elevated. So for example, inflammation within the prostate can cause a PSA to be high, and many people may have inflammation for various reasons, infections, trauma to the prostate. So many other, and in fact, just as part of aging, our prostates enlarge and get bigger. And so that whole process causes there to be more prostate tissue, and that also can cause the PSA to go up. And we do see that men will have rising PSAs as they get older, and it's because of just the benign, non-cancerous growth of the prostate gland. So many reasons to have an elevated PSA. There's been a lot of controversy surrounding PSA because it is not that specific a test. If your PSA is elevated, it doesn't mean you have cancer. But what we have seen, it has led to the increased detection of prostate cancers. And therefore, we as urologists still feel strongly that it is an important part of our screening process. As part of screening, we typically get a PSA test, and we do a prostate exam, which is a rectal exam to feel the prostate. We're feeling for firm areas. These are the two methods we currently have for screening to detect men who are at increased risk. So if your PSA is elevated, we don't say you have cancer, but we say that you may have an increased risk, and that would lead us down certain pathways for us to do further testing and evaluation, and eventually maybe even a biopsy to be able to determine whether you have cancer there. Now, who should get PSA testing? And this has been a point of controversy for the last 10 years. We used to recommend it for everybody over the age of 50. So I'll give you the current AUA guideline. AUA is the American Urological Association. And our current guideline says that for men over the age of 55, between 55 and about 70, if you're at average risk, meaning you're not African-American, you don't have a family history, then it is something that should be discussed with your primary care physician to determine whether screening would be something that you would like to do. So they kind of consider it optional, but we as urologists do advise to do it because it can lead to the earlier detection of cancer. It has been shown to reduce your overall risk of dying of prostate cancer by screening. And so for men between 55 and 70, at average risk, we recommend once a year PSA and prostate exam. If you are, if you have an increased risk, meaning you're African American, or if you have a strong family history of prostate cancer, I personally would advise starting much earlier than 55, typically around 40 to 45, and that's what the American Urological Association guideline says too. It says actually starting at the age of 45, you can start screening earlier if you have an increased risk. It also mentions that risks of testing should be weighed against the potential harms of testing. So doing a PSA test alone is not harmful to you. It's a blood test. However, the harms that they're referring to are the harms that can occur along the pathway down the road. So the PSA test, if it's abnormal, can lead to further testing. That could eventually lead to a biopsy. A biopsy can lead to a cancer diagnosis. And a cancer diagnosis can lead to eventual treatment. And we know that treatments have certain risks of side effects. And so, you know, if you get a PSA, the concern is everybody who's diagnosed with cancer, and if they get treatment and those treatments lead to side effects, then the actual process of PSA testing led to an increased risk of side effects. Now, that used to be more of the case when anybody with prostate cancer was recommended to have treatment, but nowadays we're much more selective, and we have diagnostic testing we do to really try to determine who really needs a biopsy. And if they have a biopsy and they're diagnosed with cancer, not everybody, we're not going to recommend treatment for everybody, because prostate cancer is a slow growing cancer. Some men will have less aggressive forms of prostate cancer that may not require treatment. And so with our current protocols, our current diagnostic evaluations, I think we're able to test for prostate cancer. We're able to determine better who needs biopsies, and if they're diagnosed, who actually needs the treatment and would benefit from the treatment. And in that way, we can try to avoid unnecessary treatments, unnecessary harm to patients. So we feel that getting a PSA test does not necessarily increase risk of harm significantly, and therefore we do advocate for it.
Okay, so thank you. So you started talking about diagnoses then. So how is prostate cancer diagnosed? Is it biopsy alone? Is it PSA? Could you maybe expand upon that a little bit?
So as we talked about, screening is a process where we're looking for patients who are at risk, but it is not a diagnosis. The ultimate diagnosis eventually comes from an actual biopsy. And the biopsy is really just, it's a short procedure. It's not a large procedure. It's about a 10-minute procedure. We do it under ultrasound guidance. We put an ultrasound probe into the rectal area. And in my practice, we tend to do it with people asleep. I think people appreciate that. They're more comfortable. So we do put people under anesthesia. We put an ultrasound probe. We're able to visualize the prostate. And then by using the ultrasound guidance, we can direct a small needle that goes through the wall of the rectum into the prostate tissue, and we can grab little pieces of tissue with that needle, and we send it for testing. That was the conventional way of doing a biopsy. Over the course of the last 10 years, we've also incorporated MRI imaging in collaboration with our radiologists. Probably about 7 years ago, we started a MRI prostate cancer imaging program, and it's really been helpful in us being able to find patients or find cancers within the prostate. So we tend to do that much more commonly now, where we get an MRI prior to a biopsy. The MRI then shows us the prostate. It shows us if there is a suspicious area. And then using special technology that has a tracking system, we take the MRI images and we take our actual ultrasound at the time of the biopsy. So we call that a fusion biopsy, where we fuse the MRI and the ultrasound images. And we've been doing many more of those biopsies recently, because we do feel that it's helpful. We've had many cases where if we had not done that, we would have missed the cancer. So it's increased our ability to find and target cancers. Also, we can detect what's considered the more clinically significant prostate cancer. MRI has been shown to correlate better with finding potentially aggressive disease, which is the stuff that we really want to identify. So that's how a biopsy is done. It's typically anywhere from 10 to 20 minutes or so. It's an outpatient procedure. Patients go home the same day, and it's reasonably well tolerated. So.
Well, thank you. So now, unfortunately, let's say the results come back and somebody is diagnosed with prostate cancer. What are, some of the treatment options, and including, surgical interventions? What are the most cutting edge options men have available to them?
Yeah, so for my patients, if we have a patient who's found to have cancer, I spend a lot of time, first of all, just going over the diagnosis. The first step is to determine how aggressive the cancer is, at least based on what we can see and what we can know. So we do what's called risk stratification. We categorize patients into various risk groups. Patients could be very low risk, have low risk disease, or they could have very high risk disease, and there's a whole spectrum in between. And so the first step is really to determine how aggressive the cancer is. And then based on that, we can decide whether someone needs treatment. And there's a lot of factors that go into this decision, not just the aggressiveness, but we have to look at patient's age. We have to look at their other medical conditions. Prostate cancer is a slow growing cancer. On average, if it's going to cause problems for people, it can take 10, 15 years or longer. So if someone's 90 years old and they have a non-aggressive prostate cancer, we're not going to do anything for that cancer. So we have to kind of look at the overall picture. But if someone is of a relatively younger age, they're relatively healthy, and they have a more substantial cancer, then we're going to talk about actual treatments. Now, in the cases of low risk prostate cancer, then we may consider one of the options is called active surveillance. And what that means is basically monitoring the cancer, where we follow PSAs, we may do repeat biopsies to make sure the cancer is not getting worse, but we don't actively go in and do something to treat the cancer, because we feel that those cancers, many of them may end up being what we call indolent. They may not cause problems for that person. And so active surveillance is definitely a consideration in a lot more patients now compared to what it was 10 years ago. And we're doing it and we're advocating for it a lot more. So we do consider that a treatment option is called active surveillance. The second, and then the two mainstays of therapy, and there are pros and cons to each approach, but we typically consider, if you're going to treat the cancer, we typically consider radiation treatment or surgery to remove the prostate. And these are broad categories, but radiation, there are different types of radiation. There are different approaches to delivering radiation. And we really have to kind of look at the specifics of that person's case to determine which approach may be best for them. But in general, radiation is done from outside the body, and it is delivered to the area of the prostate, and sometimes to other parts of the pelvis, for example, the lymph nodes. And the goal of radiation is actually to damage DNA within the cancer cells. And by damaging that DNA, hopefully eventually lead to death of those cancer cells. So radiation works over time, but radiation is delivered through various methods, and the advantages are it's non-invasive, doesn't require entry into the body, no surgery is required. So those are the main advantages. And then, you know, there are potential side effects with radiation as well. And again, we review all of those prior to determining whether someone wants to pursue radiation treatment. In terms of surgery, the general goal is remove the prostate. In addition to the prostate, we remove two glands attached to the prostate called the seminal vesicles. In many cases, we will also remove lymph nodes from the pelvic area called a pelvic lymph node dissection. The cutting edge way to do surgery these days, and this has been around for the last 20 years or so, is through minimally invasive approaches, which is what I specialize in. And we do robotic surgery. That means is we make several small incisions across the abdomen. We place a camera into the body. We place robotic instruments, and I sit at a controller, and using hand controllers and foot controllers, I can direct the robotic instruments to basically perform the surgery inside the body. So we can remove the prostate. We then reconstruct and we put the urethra back together with the bladder. We remove the lymph nodes, and we leave a catheter in the bladder to allow our reconstruction to heal. We remove the prostate through a small incision that's about this big, and we send it for testing. And then we close up the incisions. And the biggest advantages to this approach, because of the smaller incisions, people have less pain. It's a shorter recovery process. They're in the hospital for a shorter period of time. We have a lower risk of bleeding. The vast majority, about 98% of our patients, leave the hospital in one day. And their short-term recovery is a lot faster. So their convalescence is shorter. Pain goes away typically within 3 to 4 days. Most patients don't even take narcotic pain medications when they go home. They take Tylenol and Advil. So these are some of the advantages to minimally invasive surgery. There's pros and cons to surgery as well. Not everybody's a great surgical candidate. But surgery can lead to certain side effects like incontinence of urine and erectile dysfunction. So we always have to each person is an individual. We have to see what extent of cancer they have. We have to see whether they're reasonable surgical candidates. We have to look at the pros and cons of the various treatments and determine individually what may be best for that person. So it is a process. When you're diagnosed, we have to discuss all of these things. In some cases, patients will get additional opinions, meet with our radiation oncologists as well. These are for patients who have localized prostate cancer. If the cancer, God forbid, happens to be more extensive and is advanced and has spread beyond the prostate into other organs, we call that metastatic prostate cancer. We have a whole different treatment protocol in those situations. And we start patients on hormone therapy. Hormone therapy is medications we give to lower testosterone. Testosterone acts as a fuel for prostate cancer. So by taking that fuel away and reducing testosterone, we can cause the cancer to kind of shrink and be suppressed. We may consider other treatments like chemotherapy, other types of hormone therapy. And then there are even other treatments we give when the cancer stops responding to those treatments. So advanced prostate cancer is a whole different entity, and the treatment protocols are different for those patients.
Thank you. So let's talk about some non-cancerous prostate conditions, such as benign prostate hyperplasia or an enlarged prostate. Can you explain what they are and kind of how common it is among men?
Sure. Yeah. So it's probably it's more common than prostate cancer because all men have prostates, and virtually all men will have growth or increase in size of that prostate as we age. And I would say probably 65 to 70% of men over the age of 65 will have some urinary symptoms related to their prostate. And what that means, as the prostate grows, we talked about it earlier, it wraps around the urethra. As it grows, in some patients, it causes inward compression and it causes slowing of the urinary stream. And gradually, over time, the bladder has to work a lot harder to push urine through. And that leads to thickening of the bladder muscle and changes to the bladder and changes to your urinary function. So people will start noticing that the urinary streams start slowing down. They may have to go more frequently to the bathroom. They may not empty their bladders fully. They may have to start waking up at nighttime to urinate. They may even have to start having to rush to get to the bathroom and have a hard time holding the urine. So these are some of the symptoms we see just from an enlarged prostate, and they are very common symptoms. As I said, 65 to 70% of men over the age of 65 will have these types of symptoms.
Like what are the signs and symptoms of an enlarged prostate? Just the urination and the frequent urination?
Correct. So those would be the most common symptoms that we see. Rarely you'll see patients that may not have had many symptoms, or maybe they had some symptoms, they were gradually progressing, and all of a sudden they can't urinate. We call that urinary retention. In our practice, we see it, patients have never seen the urologist, all of a sudden they can't pee. Now, maybe it's not due to an enlarged prostate. There are certain medications and other conditions that can cause those problems. But in many cases, there's usually still some underlying enlargement of the prostate. So you can see retention. You can see any number of these urinary difficulties. And so a lot of times we have many patients in our practice who have those symptoms, and we evaluate it here in the office. We do a prostate and we check their PSA, we check their urinary flow, we check to see if they're emptying their bladders well. We may start patients on medications because that's usually the first line treatment for some of these conditions. And in some cases, medications may not do the trick, or patients may still progress while on medications. And then we start discussing other surgical options. There are some interventions that we can do to kind of help open up the prostate area, to allow patients to urinate better and empty their bladders better and relieve some of the symptoms they have. So
how do you diagnose for it? And then, I guess when should somebody seek treatment too? Because right, if they're
Right.
having like urination issues, you know, it's the
Sure.
point, when do you seek it and how do you diagnose for it?
So what I tell patients is, if you have developed some of these symptoms, and if the symptoms have become bothersome to you, so basically, you know, you're really struggling to urinate during the daytime, you're going every hour, the stream is so slow, and it's become a bother or a nuisance to you, then definitely at that point you need to be evaluated by us. As I mentioned, the evaluation, we do prostate in the office. We have you urinate for us in a machine that measures your flow. We do an ultrasound of your bladder. We check and see how well you're emptying your bladder. And that's how we kind of evaluate these conditions. And then based on those features, then we will determine what type of treatment may be appropriate for you. But anybody who has any of those urinary symptoms and has some amount of bother related to it. We see a lot of men who have some of those symptoms. It's not really bothering them, but they're not sure. They want to just get checked out and make sure that everything's okay. And it's reasonable to come see us. We may just say, well, I don't think you need any treatment. You don't need any medication, but we do see some issues here. Maybe we'll recommend just monitoring to make sure things aren't getting worse over time.
Sounds good. So you mentioned treatment options. What are treatments for, you know, benign hyperplasia, prostate hyperplasia?
So the first, as I mentioned, the first line of treatment is typically medications, just because we always go with the least invasive, intrusive options first. Medications, although they can still have some side effects, in many cases will help with the symptoms and may kind of abate the symptoms. We also have studies that show that using these medications will slow down the progression of this process and will reduce your risk of having to have surgery related to issues, surgery because of issues related to these problems. And so there are different categories of medications. The first are called alpha blockers. They work by actually relaxing the smooth muscle around the prostate and allows the prostate to open up a little so urine can go through easier. Should give you a better stream and better emptying of the bladder. There's another category of medications called 5-alpha reductase inhibitors. They work by actually shrinking the prostate over time. They take 3 to 6 months to take effect, but as they do, then it may help also improve the urinary flow and some of the other symptoms as well. So those are the two broad categories of medications we use for those issues, and they're used very commonly.
Okay, so you had also, I guess, talked about an inability to urinate or incontinence. So can you give us a brief overview of what urinary incontinence is and what causes it?
Yeah, so inability to urinate is the opposite. So inability to urinate means nothing is coming out. You can't urinate at all.
Oh, that incontinence.
Yeah, and so in some men who have that problem, it's due to their prostate. And if medications don't work, then we then have to go to surgical interventions to help with that. Incontinence is the opposite, where urine is coming out when you don't want it to come out. Basically, you're unable to hold the urine. There are different types of incontinence. And the one type is called stress incontinence, where urine leaks out when you cough, you sneeze, you laugh really hard. It's due to the increased abdominal pressure, and it's due to weakness of the muscles around the urethra. Although it can happen in men, it tends to happen much more commonly in women who go through childbirth and all of these things that actually cause weakening of the pelvic floor muscles along with the aging process. And that leads to basically what we call stress incontinence. So leaking when you cough, you sneeze, things like that. The other type of incontinence we call urge incontinence, and it happens due to overactivity of the bladder. Urge means you have a strong desire to get to the bathroom, and to the point where sometimes you can't control it. And if you cannot hold it, it'll start coming out on its own. So we call that urge incontinence. And some people have a mixture. Some people have what's called mixed incontinence. They have a combination of both. But basically, incontinence is something where you cannot control the urine. It comes out when you don't want it to. There are different types, and we manage them differently. So stress incontinence, we're going to do things to try to help strengthen the muscles of the pelvis. We'll encourage women to do Kegel exercises. We have things called biofeedback, which is kind of like a physical therapy for the pelvic floor muscles. We can actually show you how well you're contracting the muscles. We can ask you to do certain exercises to strengthen the muscles to help reduce the incontinence. If that doesn't work, there may be surgeries that can be offered if you have leakage with coughing and sneezing. Urge incontinence is completely different, and the mechanism is different. It has to do with changes that occur to the bladder due to changes in innervation to the bladder. People may have had damage to the spinal cord. People have had injuries. But in general, also as part of the aging process, the way the nerve impulses go to the bladder, they change over time. And so people have a hard time. The bladder's job is to relax, to be able to store urine. And if the bladder cannot relax and allow the urine to be stored, then it starts coming out on its own. So it's an issue it's a problem of bladder relaxation. And so our first line of treatment tends to be medications that work to help relax the bladder muscles. And so we typically will start patients on medications. We'll also talk to them about their fluid management, how much fluids do they drink, try to avoid bladder irritants, things like caffeine, alcohol. They act as diuretics, they increase urine production, and they are going to make it harder to hold the urine too. So in some cases, we may be able to manage just through modification of certain behaviors, reducing your fluid intake, reducing caffeine intake, reducing alcohol intake. And in some cases, that's all people need to do. And if they do that, then they're going to be able to hold it well enough to get to the bathroom. Now, if they're not able to do it with behavior modification, then we start discussing medications that relax the bladder. Now, if that doesn't work or they have side effects related to it, then we do have certain interventions we can do that are a little bit more invasive. For example, Botox injections have been done where Botox can be injected into the bladder muscle to help cause relaxation of the bladder muscle. So Botox injection, we know that these problems occur due to changes in nerve impulses. And so we can actually modulate nerve impulses to the bladder. One approach is called peripheral nerve stimulation. It's similar to acupuncture. We put a needle into the nerve in the ankle, and we stimulate that nerve. And that nerve to the leg actually originates from the lower spinal cord, which is the same area where the nerves to the bladder come from. And so by sending impulses through the leg nerve, it actually alters the nerve impulses that go to the bladder, allowing it to relax. So we call that peripheral nerve stimulation. And another approach is something called a bladder pacemaker or a neurostimulator or interstim. And what that is, we insert electrodes and then we would implant a little pacemaker device under the skin, and that pacemaker continuously sends impulses through those nerves, and it allows the bladder to help relax, to help with these issues. So the more invasive treatments we reserve for patients who have failed the more conservative management and who are still bothered by their symptoms. Some people may not want to pursue the more extensive interventions. Then we try to maximize the medications. And those patients may still end up using some pads, to help with the incontinence issues. So again, these things are all individualized depending on the age of the patient, their medical condition, how important it is to be fully continent for them, things like that. So these are kind of the considerations that we take into account.
Great. Thank you so much. That was very comprehensive. So I just want to be able to give our audience some time to ask some questions as well. And I know we have a few in our chat feature. So at this time, I'm going to open it up to questions from our audience. If anybody does have a question, please feel free to go onto the chat feature and just type in your question. So I do, let's see. So the first, we talked about treatment options. Let me just see. Here's just a quick question. What are some of the things that can be done to prevent prostate cancer?
Great question. So there have been a lot of studies that have been done to look at prevention. A lot of them have been dietary studies, vitamins, things like that. There's a study called the SELECT trial that looked at vitamin E and various other things. Most of those studies, because there was data from basic science, from animal models, cell studies that showed potential benefit, they did wider general population studies. Unfortunately, those studies didn't show a significant benefit to vitamin E or certain vitamins, okay? People have looked at certain medications. For example, the type of medication that shrinks the prostate that we use for benign enlargement, that was looked at to see if it reduces your risk of developing prostate cancer. And several large important studies were done. And those studies actually did show there was about a 25% reduction in risk of developing prostate cancer with those medications. But the problem was that patients who were on those drugs, if they did develop cancer, they had a slightly higher risk of developing a more aggressive form of prostate cancer. So those drugs have not been routinely promoted for prevention. Okay, so we don't use them, we don't prescribe them specifically for prostate cancer prevention. We do know that diet plays a significant role because a lot of the foods we eat may be carcinogenic. That means cancer causing. Okay, so we recommend a diet that's high in fruits, vegetables, antioxidants, whole grains, fish. And with the meat, we know that meat cooked at high temperatures it's that char and that charring process that may have a carcinogenic property. So we recommend minimizing that because that could be linked also to increased risk of cancer. And you know, in general, processed foods and foods that are high in sugars and things like that should be avoided in general. So I think a healthy diet is important for prostate cancer prevention, but other than that, we don't have any specific medications or vitamins that we advocate specifically for that goal.
Okay. Now, you may have touched upon this, but how accurate is the PSA test?
It's not that accurate. And we kind of had the discussion at the earlier portion of this meeting, but yeah, it's not super accurate when a PSA is elevated, especially if your PSA kind of fluctuates and goes up and down and all over the place. That could be an indicator that you have inflammation within the prostate. But it is in cases where, you know, it is elevated, consistently elevated, or you see a consistent rising trend, or if it's also associated with an abnormal prostate exam, those patients are going to be at much higher risk of having prostate cancer. So an elevated PSA does not mean you have cancer. For example, we have a test called the 4K score, which includes PSA, but we look at other factors and it determines specifically your risk of having an aggressive form of prostate cancer. And that's what we need to know. We need to know that risk. We don't need to know your overall risk of prostate cancer, because if you have a less aggressive form, it almost doesn't matter. And so this 4K score has been more helpful for us. So if you have an elevated PSA, we may recommend getting additional testing like a 4K score or a prostate MRI. And once we kind of have all that information, then we can do a better job, increased risk of having a more aggressive form of prostate cancer.
If the PSA is not accurate, why is it recommended? And could you also explain why some men, their PSA fluctuates? I guess not everybody's does, correct?
Not everybody's does, but in the cases where it fluctuates, it does make PSA difficult to use or interpret. But that's where we then bring in some of the other testing modalities. So if you're right, the PSA is not always accurate, but it's an easy test to do, and it does lead to increased detection of prostate cancer. So when a PSA is elevated, it leads us down a pathway where we can go looking for that increased risk further. But we're not right, at least for now, we're not using a 4K score as a screening test. It's a specialized test, and it's not easy to order or request. So it's not it hasn't been authorized to be used as a screening test. So PSA currently is indicated for screening purposes. Screening just means increased risk. If you're at increased risk, then it leads us down a pathway where we can then do further evaluation to see if you truly have prostate cancer. So even though it's not accurate, it leads us down a pathway that can lead to earlier detection of your cancer. Great. So that's why it's used. So, but currently we don't have any other tests that are approved for screening purposes. We can't do an MRI on everybody. So all men can't have an MRI. That would be too costly. That would put too much burden on our healthcare system. Yeah. So we have to look at cost. We have to look at, and we have to look at guidelines. We have to look at what insurance companies allow and authorize to these days, because we are restricted by those things as well.
So earlier, you talked about supplements, and one of our audience members has a follow-up question. If you could maybe speak to supplements like super beta prostate or prostagenics. I'm not familiar with that one.
I mean, I'll give you my general take on supplements. I don't think there's anything wrong in taking supplements. If you're going to take supplements, I would advise it for patients who have urinary difficulties. So you're not taking it to reduce your risk of prostate cancer. You're taking it to try to help improve your urinary flow. And there is some data to support use of some herbals, things like saw palmetto. So there may be some advantage in some patients with those things. And that is up to the individual patient. If they want to try it, I don't think there's anything wrong in trying it. I would say that if you're still having symptoms, it's not helping you, then at that point, you probably do want to see a urologist and have them evaluate things further. So it may help certain people. It may not help everybody. Also, these are herbal products, so they're not prescription products. They're not regulated by the FDA in the same way as prescription drugs. And so there is variability in what you're getting with those products. But that's my general take on it. I don't see anything wrong in it. And I do think that they may be helpful for certain people.
Thank you so much. So I know we're coming up to our hour, so and I don't see any additional questions. So I'd like to thank you, Dr. Dave, for a very informative webinar this afternoon. And to our audience, thank you for participating. This concludes today's webinar. Please remember that the opinions expressed here today by our medical expert, are not a substitute for medical advice from your own physician. If you need a physician, please call 1-888-724-7123. And for more information about Robert Wood Johnson University Hospital, Somerset, please visit us at www.rwjba.org/Somerset. Thanks again, Lynn, and have a great afternoon.